please?
Yeah, my name's Bridget. I'm an Elderly Care Facilitator to GP Surgery. I started work at the surgery in July 2012 as an admin assistant, but began this role in November 2014. I studied English and American Literature at Keele University, so I don't actually have a background in elderly care, but just showed particular interest and got given the opportunity. Yeah, basically what my role includes is performing sort of annual health assessments on patients either over the age of 85 with dementia or that are housebound. I visit them in order to gather medical, social, psychological and functional information about them, and just to see if there is anything else that we as a GP surgery can do for them, or if we can point them in the direction of somebody else that might be able to help. I also try and keep in contact with them, obviously more than just on the annual basis. I telephone them to check they're alright. I'm sort of a point of contact at the surgery as well as the middleman, so that they have somebody to talk to that isn't necessarily the GP if there's something that they need. My role isn't to sort of diagnose or sort of maintain conditions or anything like that. I'm just there to sort of build a relationship with the patients and their carers. Basically, I have time to do the things that the GP wouldn't necessarily have time to do in their consultations. So when you go in to see a GP, you go in with a particular intent to go. Whereas when I go to visit, it's sort of a more relaxed atmosphere. We can talk about things that perhaps are concerning you, but you wouldn't necessarily talk to the doctor about it because you don't think it's particularly that important. The GPs have found it useful that they refer patients to me, as do the practice nurses, if they don't necessarily fit into my group but they're concerned that they might need a little bit of extra support, then they ask me to go and visit them as well. We work a lot with different charities such as Age UK, with social services. I'm currently sort of building a relationship with social services so that we can sort of help each other and feedback. We've currently set up a system with Age UK where I refer patients to them to complete attendance allowance forms, because obviously they're quite difficult forms to complete. I'm also working with the Alzheimer's Society. I'm a Dementia Friends champion, so I give sessions on sort of dementia awareness for the general public. But charities mainly, but also a few different sort of health professionals like OT and physiotherapy. It works okay. There's still a lot of improvement that needs doing in sort of the communication between the different sort of rehabilitation processes and that sort of thing. But I think particularly with social services, they're finding it quite useful to have a contact at the surgery that's not necessarily a doctor and that knows the patients. I have actually attended a few assessments with social services, which they found quite useful because I can give a background about the patient that maybe necessarily they wouldn't know otherwise. At the beginning, I attended a few sort of registrar tutorials with the GPs about elderly care, and I went out on some visits with practice nurses just to sort of get myself into the role. But there was no particular training needed. It was sort of a learn on the job sort of role, and it is changing all the time. We've developed it so we find that it's better coming from somebody who hasn't necessarily got a medical background, because sort of I pick up on things that aren't necessarily medical. And also sort of the fresh pair of eyes as well, that things that necessarily the GP won't know but notice because obviously they've got other things to focus on, but the patients then talk to me, and it's just sort of gradually progressing, and obviously I'm making connections with different charities and different things as we go along as well. The patient contact, really. I've met some very, very nice people. It's a little bit cheesy, but I like the fact that I can make a difference, and I do feel that the feedback that we get, they do feel that makes a difference to them, having somebody else that they can call if they need to. Particularly when I first started, I did have a few patients that were concerned because I didn't have a medical background, I also had a few patients that were concerned that I was there to just diagnose them with dementia. But as I've got to know the patients, because I've visited them quite a few times now, they've become that they're more accepting of me, and they realise that I don't necessarily need a medical background to do what I'm doing. It was mainly through talking to them, through explaining what I was there to do, and the fact that I was going to feed it all back to the GP. I think it's just sort of building the relationship that sort of made them more confident in me, and me more confident in myself, hopefully. They seem to find them very useful. I think they're very thorough. They always say they're very thorough, because when I ask them at the end if there's anything else, they think I've covered most of it. I think what they seem to like the most, particularly the carers actually, is the fact that they have got somebody that they can ring if they're not quite sure of how to go on with something. Sometimes I just get a carers ringing just for a chat, just to tell me how things are going and things. It's just someone extra to talk to that's not necessarily in the situation but knows the situation. We're hoping to sort of progress it so that if with sort of unplanned admissions, if our patients are to go into hospital, helping them come out of hospital quicker, possibly making the hospital more aware that they've got me here, so that we can work with them, because obviously once somebody goes into A&E, if they are sort of frail elderly patients, it's difficult to get them out because they're concerned of what sort of thing they've got in the home and what care they'll get. But obviously I'm aware of that. We've got all the information, but it's just sharing it with the hospitals. So we're hoping to progress in that way, really, along with obviously hopefully covering a few more things, maybe on the visits, maybe sort of end of life planning, that sort of thing. I don't think so. It's hard to think, really. I think most of it's gone well. We did initially start with practice nurses doing the visits, but it was found that the practice nurses got sort of tied in with the medical issues rather than the other things like the functional assessments that we wanted. So maybe, I think if you spoke to Dr. Leshko, he might say that we'd initially start and just not include the GPs or the practice nurses. But other than that, I can't really think of anything. The main piece of advice I'd say is to listen to what the patient wants, what their wishes are, and try and find a way that you can work with that to make sure they're getting the best care, but make sure they're happy with what you're providing for them.